Thank you for that introduction. So, Paul Hamlin, when he asked me to give this talk, I had prepared a completely different talk for this. And he said, no, I want you to talk about the NCCN guidelines. And I said, oh, that's an interesting topic. So this is a little bit of opening the curtain in the Wizard of Oz. There's a lot of questions about, what is the NCCN process? How does it work? So what I'm going to try to do is illustrate the process in the lymphoma panel to illuminate the guideline process. These are my disclosures, and disclosures are actually quite an important part of the NCCN process. So we have to start with the 2011 report from the Institute of Medicine. They published a seminal paper on guidelines we can trust. These were these were largely theoretical, not actually practical applications of a set of measures and a set of guidance for guideline production. But importantly, they wanted it to be based on systematic review of existing literature, and certainly no one would disagree with that. Be developed by knowledgeable, multidisciplinary panel of experts and representatives from key affected groups. Consider important subgroups and patient preferences as appropriate. And right here, we already see a conflict between the first goal, based on systematic review of existing evidence, and individual patient subgroups, because sometimes the individual patient subgroups simply do not have systematic evidence because they're too small. We want to have them based on explicit and a transparent process that minimizes distortions, biases, and conflicts of interest. Provide clear explanation of the relationships between alternative options, and provide ratings of quality, and be reconsidered and revised as appropriate when important new evidence emerges. Okay, so what were the standards? Transparency, management of conflicts, guideline development, group composition, and interestingly, in the IOM world, they didn't want domain experts to be involved. They actually wanted guideline experts to be involved, and I actually disagree with that quite strongly, and we disagree with that in the NCCN. Clinical practice guidelines and systematic review have to intersect, and we have to have clear evidence foundations and strength rating of recommendations, and then we have to actually let everyone know. They should be externally reviewed and updated on a regular basis. So what's our process? The NCCN is comprised of a large number of high-quality national cancer centers, and the membership has grown steadily over the years. This is the current composition. Each member institution has one representative for each of the guideline panels, with some exceptions, including the NHL guideline panel, where we actually have 3 representatives, but that's, we'll get into that. So what about the NCCN guidelines? Well, to be useful cancer guidelines, these actually have to be comprehensive, again, across all stages, modalities, and the continuum of care, not just for first-line treatment, but for second and third-line treatment. There are 44 multidisciplinary expert panels, and it takes advantages of the best practices in NCI-designated cancer centers. It includes cancer screening, diagnosis, treatment, and supportive care. They're updated at least annually and up to 4 times a year. The lymphoma guidelines were updated 3 times in 2016 so far. I don't think we're going to have another update. The categories of evidence and consensus are designated for each recommendation. The process is transparent, and all votes are actually recorded and available. The idea is to provide a suite of tools to provide quality oncology care. So the key here is the continuum of care. High-level evidence may not exist across a continuum of care. It might exist in first line, but it might not exist for all patient populations. So there are always going to be gaps in the high-level evidence, in meta-analyses and phase 1 trials. And as a result, these gaps have to be filled. And the NCCN process is to fill these gaps with expert consensus. This varies a little bit from the IOM standard. However, to provide a continuum of care, and you just sticking with high-level evidence, you will leave too many people at sea. I actually think it's much better for a panel of lymphoma experts to suggest a treatment where there's lacking high-level evidence that they can agree on than to ask a community doctor who sees 6 or 7 lymphomas a year to come up with their own idea as to what should be done. So what's an example? Here's diffuse large B-cell lymphoma. Well, this is pretty easy. R-CHOP chemotherapy, we're done, right? You know, we have lots of evidence, multiple randomized clinical trials that support the use of R-CHOP given every 21 days. This is a category 1 recommendation. I'm going to get into that. However, the guidelines are that R-CHOP 21 is fine if you're fit and you have a good heart, but what happens if you're elderly, you're frail? These are subpopulations that we have to deal with, and in fact, in the NCCN guidelines, we provide options for those patients. If we look at the relapse setting, for patients who are not candidates for high-dose therapy and autologous stem cell rescue, what many of you call autologous transplant, but I don't like the term, we have to provide alternatives, and unfortunately there are no large-scale randomized trials that tell us what to do in this situation. So as a result, you end up with a bit of a laundry list. That's one of the criticisms of the NCCN guidelines, and in the part later in the talk, when I talk about the future, I'm going to try to address how we're going to somewhat clean this up. So who makes up the NCCN Lymphoma Panel? Well, we have representatives from each member institution. We also have representatives from pathology, radiation oncology, medical oncology, a patient representative, and importantly, dermatology, because a number of our diseases have important dermatologic features. So a little bit of a history. Our first guidelines were published in 1995. It included 8 diseases. We currently cover 20 different diseases, and we've even given up 2. We gave up CNS lymphoma to the CNS panel, and we gave up ALL to lymphoblastic lymphoma to the ALL panel. We also have specialized guidelines to aid in diagnosis and use of genetic testing. We have specialized guideline in the use of radiation therapy, supportive care for lymphoma, and special consideration for use of targeted therapy. The guidelines and manuscript exceed 500 pages. It's not sort of light evening reading. In 2017, because of the size and scope of the guidelines, we're actually going to divide them into 3. There's going to be a B-cell NHL panel. There's going to be a T-cell NHL panel with cutaneous B-cell lymphoma, because they have all the dermatologists, and a CLL panel. So what's our process? We actually have a face-to-face meeting in late June. That's scheduled to be after ASCO, EHA, and Lugano on the Lugano years. It's a 2-day meeting. We present all of the new data, whether it's relevant or not to changing the guidelines, because knowing what's going on in the field is absolutely essential to developing good guidelines. Those reviews are then discussed, and on a disease-by-disease basis, we review suggestions from the institutional reviews of the guidelines and vote on any changes to the guidelines themselves. Any change to the guidelines, all of the votes are recorded if they influence the use of therapy, and those are available and published, and that's actually a requirement of CMS, who uses our guidelines and our compendium for making coverage determinations. We do a post-ASH WebEx, and then we do ad hoc WebExes as necessary if new drugs are approved. We typically will have 2 to 3 revisions of the guidelines every year. And this is in contrast for those of you who were at the symposium yesterday. There were excellent transplant guidelines published for the use of high-dose therapy and autologous stem cell rescue in lymphoma, and they were published 5 years ago and have not been updated. We've updated 3 times in 2016 alone. This is one of the critical things. They have to be fresh. They have to be updated. So we also have to have standards of evidence. Category 1 is where there's a high-level evidence, either meta-analyses or prospective randomized trials, and there has to be uniform consensus. More than 85% of the members of the panel have to agree. Category 2A is based on lower-level evidence, typically phase 2 trials or small randomized phase 3 trials, or phase 3 trials that we feel are not designed properly, and we will not give that category 1. But again, there has to be uniform consensus, more than 85% or more of the panel members agreeing. Category 2B is when half to 85% agree that an intervention is appropriate. And category 3 is based on any level of evidence, but there's major disagreement within the panel whether it should be done, but there are at least 3 institutions who say this is what we do. So obviously we're going to take data from randomized trials, meta-analyses, non-randomized trials, retrospective studies, and historical practice patterns. The process is somewhat complex. We have a panel meeting, then the NCCN staff reviews all the changes we've made. I then review the NCCN guideline that then is sent out to the panel members, and it's published. Then each year, we send the guidelines back to the institutions. The institutions get to review them, so if there are, say, 17 lymphoma doctors at an institution, I don't know what institution I'd be talking about, then multiple people have an ability to get eyes on the guidelines and make suggestions, and then the whole process starts again. Conflict of interest is really a major problem, and so no industry funds are used. This is supported entirely by member dues. Panel members are not paid for their work on the guidelines, and it's estimated that more than 40,000 hours of free time is given to the maintenance of guidelines. Industry representatives are not at meetings. Panel members are experts, and the experts are frequently involved in trials. All of the trial relationships are disclosed, and members are excluded from votes if they have a significant conflict. How do guidelines fit into decisions about treatment? Well, we have to have a decision at each point in treatment: diagnosis, evaluation, first-line treatment, second-line treatment, et cetera. the problem is that we will not have perfect data for every single node on the pathway. And we also have to have specialized treatments tailored to patients that are special populations, such as those with significant comorbidities. But the point is to provide this comprehensive continuum of care that allows for practicing oncologists to effectively treat diseases that they don't see every day. We're not trying to create a cookbook. We're trying to create guidance and alternatives for patients and caregivers. The NCCN Drugs and Biologics Compendium arises directly from the guidelines. Each node where there's a drug recommendation is recorded in the NCCN Compendium, it's updated continuously to the bane of my existence because I'm re-editing this like 3 times a year. Drugs are named, and this is used by payers, and it's also accepted by the Centers for Medicare and Medicaid Services, CMS, for coverage determination. And as a result, all additions and subtractions from the compendium are voted, recorded, and available publicly. And anyone with a conflict of interest is excluded. There are 3 compendium that CMS recognizes, and the NCCN compendium is one of them. Increasingly, a large number of payers use the NCCN guidelines. I actually had a very funny situation. I had a challenge to a recommended therapy, and the guy said, I'm looking at the NCCN guidelines, and I said, can you turn to the first page? And he said, yeah. And I said, can you look at the top left-hand corner? And he said, yeah. He says, okay, it's approved. He was trying to quote back my own guidelines to me, so that was sort of an interesting process. Frequently and importantly, drugs are included in the compendium for off-label uses. This is actually really an important use of the compendium. Why is it? Because many nodes on a guideline, I don't care if it's lymphoma or any disease, will not necessarily have adequate numbers of patients to allow for FDA approval. For instance, yesterday I discussed idelalisib in the treatment of marginal zone lymphoma. There were not enough patients to rise to allow the FDA to approve idelalisib for the treatment of marginal zone lymphoma, but because of the excellent activity in the patients that were included in the study, the NCCN guidelines actually include idelalisib for marginal zone lymphoma. And so this is really an important aspect of what we do. So I'm going to try to use some of the decisions we made to help illuminate the guideline process. So let's look at follicular lymphoma. I think this is a good disease because it's very controversial. So what, as a group, do we feel? And the panel really feels that overall survival is the key, okay? However, in follicular lymphoma, there are some problems. Overall survival is a really difficult endpoint. When overall survival is improved, the treatment becomes the standard of care. Overall survival is unlikely to be improved if there's not improvement in progression-free survival. However, the reverse is not true. Progression-free survival is not necessarily a predictor for improvement in overall survival in this disease. So this results in this phenomenon, and this is a little tricky. So if you have a randomized trial, treatment 2, and compared to the standard, treatment 1, and there's an improvement in progression-free survival, but not overall survival, then treatment 1, the original standard, remains a viable option, And the decision to use treatment 1 or treatment 2 is going to depend on the clinical circumstances and discussions between the patient and physician. So, if all diseases were large cell lymphoma, it'd be easy. Progression-free survival virtually marches in lockstep with overall survival, but in follicular lymphoma, that's not the case. Improvements in progression-free survival can be quite substantial, with only minimal or no improvements in the overall survival. So we've been in the hunt for new endpoints, and the LymphaCare study, which I took part in for a better part of a decade, we wanted to analyze were there a group of patients at unusual risk, and when you look at the large first-line therapies in follicular lymphoma, you notice about 20% of patients relapse early, and that's in the first 2 years. And so we just said, okay, let's see what happens defining patients as poor risk if they relapse within the first 2 years, and this is actually what it looks like. Overall survival is very inferior for patients who progress within the first 2 years. These are not progress and death. These are people who are still alive, but have progressed within the first 2 years. We were able to validate this in an independent data set, so this is suggestive that this endpoint is valuable. The Mayo Clinic group took a slightly different approach to trying to answer this question, and they looked at their data compared to outcomes in the general population. So they took age and sex matched normal people in the population, their expected survival, and that's the dashed lines here, either in the US, the black, or in France, the red. So I guess if you drink more wine, you do live a little bit longer because their curves are always a little higher than ours. If you are in remission, event-free, at 12 months after the completion of treatment in follicular lymphoma, your survival is identical to that of the general population. This is actually an important observation, and it has important implications with respect to clinical trials. And that's true if all patients or specifically for patients who receive immunochemotherapy. This is independent of the type of treatment, rituximab monotherapy or other treatments. It's independent of age. You might think that, oh, gee, if you're older, that's going to be true, but if you're younger, it's not. Well, in fact, if you're less than 60 and you are event-free at 12 months, your survival is identical to age-sex matched controls. However, if you do have an event in the first 12 months, your survival is quite poor. And that's shown here, both in the US and Lyon validation cohort. Now, in LymphaCare, we said it was 24 months. The Mayo Clinic data is suggesting that 12 months is important. Well, we're both right, because we use different measures. If you want to ask, how do you correct back to the general population, EFS 12 is an adequate endpoint. However, in the Mayo Clinic data, there are critical events between 12 and 24 months that result in poor outcomes for patients. So whether you use EFS 12 or PFS 24, it doesn't matter. They both predict overall survival in follicular lymphoma. There are high-risk patients who are going to recur between 12 and 24 months. And obviously, early identification of the EFS 12 or PFS 24 patients is a basis for new trials. But ideally, we like to identify them not at time of first failure, but before they ever get treated. This is incorporated into the NCCN panel's thinking, and we want to use new endpoints so that we can update the guidelines more quickly. So we face the question all the time, is observation still an appropriate option in follicular lymphoma? The NCCN has modified the GELF criteria for treatment, and anyone with symptoms should be treated. Anyone who has moderately bulky disease, that is 3 or more 3-centimeter masses, a single mass greater than 7 centimeters, massive splenomegaly, cytopenias, threatened end organ function, concurrent histologic transformation or rapid progression are also candidates for treatment, as are all patients where there's an appropriate clinical trial asking a question. So we have 3 randomized trials in the pre-rituximab era comparing observation to chemotherapy, and there has never been a demonstrated overall survival advantage in favor of immediate treatment with chemotherapy in patients who do not meet the GELF criteria. There are some key takeaways from the largest study, which was Chlorambucil versus observation. 19% of patients with follicular lymphoma were not treated at 10 years. If you were over 70, 40% of patients never received treatment. And the delay from diagnosis to initiation of treatment was meaningful, 2.6 years. And in other series, it actually is a little bit longer. But these were all pre-rituximab. What about in the rituximab era? So the UK undertook a 3-arm study of observation, rituximab induction for 4 doses, rituximab induction for 4 doses followed by extended dosing rituximab. And in very typical UK style, they did very little. They tried to do this on the cheap. Only 3 scans at maximum were needed for the entire study. This is actually pretty impressive that they were able to get high-quality data with this little radiation. So here's the progression-free survival. The green curve shows the rituximab induction followed by maintenance. The red curve is the rituximab induction. And the black curve is observation. The primary endpoint of the study was time to initiation of next therapy. And it's interesting that there's a significant narrowing between the maintenance patients and the induction-only patients on this curve. And that's because many of these progression events are actually trivial volume progressions and result in asymptomatic patients who actually don't need treatment. So even though they progress, they actually don't need to start treatment. But importantly, at the time of the publication, there was no difference in overall survival across the 3 arms. So, so how did we interpret these data? Well, certainly PFS was not a predictor of the primary endpoint, which was time to initiation of next therapy. And we were very concerned that time to initiation of next therapy was really not an optimal endpoint. In fact, we felt that time to second therapy would be more balanced, and actually Jake Sumare, one of the fellows working with the Lymphoma Service, will actually present data at ASH showing what an endpoint of time to second treatment is. So if you think about the data, the green curve you could actually almost interpret as time to third treatment. Induction, 1, maintenance, 2, time to their next chemotherapy, 3. Okay? The red curve, they got induction and now the chemotherapy. Well, these people are only getting their first treatment. So this is a very unbalanced comparison, and if you include time to second treatment, all of a sudden these what look like dramatic differences vanish. Importantly, overall survival is an essential endpoint, and right now, to date, where we haven't impacted on overall survival. Does that mean we shouldn't be studying observable patients? No, we should be. We want to fundamentally change the natural history of the disease, but in clinical care, it does not recommend that rituximab should be used for all patients, and so we felt it was premature to recommend rituximab because of the lack of a survival benefit, but we reiterated that clinical trials are really important in this group. So what about considerations for first-line therapy for patients who need treatment? So here, the principles that we agree on as a panel is that rituximab is a good treatment, but for bulky patients is not as good as chemoimmunotherapy. We want to select treatments in an order that minimizes risk to further treatment. So for instance, if you start with fludarabine and you're thinking, oh, I have a young patient, I might want to do a bone marrow transplant in the future, not a good idea because you probably won't be able to transplant that patient in the future. And still, you know, doxorubicin came into routine clinical use in the early 70s, and we still don't know the optimum timing of doxorubicin use in follicular lymphoma. But we do know that addition of rituximab is critically important. In one of the important trials that answered this question, rituximab was added to CVP chemotherapy, showing a dramatic improvement in progression-free survival and an improvement in overall survival. With further update, the overall survival has gotten even more significant. However, the important thing here is very dramatic differences in progression-free survival, only modest differences in overall survival. Similar data was generated by the German low-grade lymphoma study group. They looked at CHOP versus rituximab in CHOP. Time to treatment failure clearly favored the addition of rituximab. Overall survival significantly favored rituximab. But interestingly, this was this strange four-arm trial. Younger patients got transplanted. Well, if you don't want to give someone rituximab, you can do a transplant, you get the same result. I would actually argue that it's better to give rituximab. So a meta-analysis has been done and clearly shows an overall survival advantage in favor of chemoimmunotherapy as first-line treatment. And so the NCCN panel says this is the standard of care. There is no question that addition of rituximab to a chemotherapy backbone is the standard of care for patients who need treatment because it improves overall survival. We also recognize that PFS benefits far outweigh the overall survival benefits, and it does not answer the question of what is the optimum R-chemo regimen. So is there data around that can help us answer this? So we have a number of randomized trials. The FOL5 trial is an Italian lymphoma study group trial comparing RCVP to R-CHOP to RFM. Here are the results. And the blue curve here is RCVP. So inferior in progression-free survival, inferior in time to treatment failure, but absolutely no different in overall survival. And interestingly, even though this is not statistically significant, the RFM curve, which looks really excellent in PFS and time to treatment failure, is actually trending down with more events, and that's because using a bone marrow toxic agent as part of first-line treatment is suboptimal. These data have been reproduced by others, including the MD Anderson in the alternating triple therapy, suggesting that if you do too much up front, you can actually hurt survival out back. Bendamustine has emerged as an important treatment option in patients with follicular lymphoma, and bendamustine was compared to, and rituximab was compared to CHOP and rituximab in this STILL trial from Germany. And if we look at all patients, there seems to be a benefit of bendamustine rituximab over R-CHOP. However, I can argue that this is the worst R-CHOP outcome in the history of mankind for first-line follicular lymphoma, and interestingly, no impact on overall survival, even with a bad outcome with R-CHOP. If we look only at the follicular lymphoma patients, the improvement in bendamustine rituximab seems to hold up. A second trial was done, which was done in the US. It's called the BRIGHT trial. You could either get R-CHOP or RCVP, or on one arm, and then the other arm got bendamustine rituximab. Unfortunately, the primary endpoint here was the CR rate, and there were secondary endpoints that have actually not all been reported yet. So the CR rate was non-inferior for bendamustine rituximab, but it was not superior, okay? So bendamustine rituximab in the STILL trial was clearly superior, was highly statistically significant for improvement in complete response rate, but not in this trial. And this trial actually included RCVP, which we saw from the Italian trial was the quote-unquote worst of the regimens. So bendamustine rituximab is good, but I don't think it's as good as the STILL trial suggests. So how do we interpret this in the NCCN panel? We recognize that overall response is not a reliable predictor for progression-free or overall survival, that EFS 12 and 20, EFS 12 or PFS 24 are better predictors for overall survival. At clinically meaningful follow-up, there are no differences in the chemoimmunotherapy that have emerged. And interestingly, if we look back and when we added rituximab to chemo, where did we start to see an overall survival benefit emerge? It was around 2 years. And now with 4 years of follow-up, we're not seeing any suggestion of an overall survival advantage emerging between different regimens, our chemo regimens. So we consider a number of our chemo regimens as appropriate for initial treatment. So there are emerging options. One of the emerging options is the use of rituximab and lenalidomide, and we consider this in the NCCN panel. This study from the MD Anderson looked at lenalidomide for 21 days out of a 28-day cycle with rituximab given on the first day of each of the 28-day cycles. Even though you could get 12 cycles of treatment, about 90% of patients only got 6 cycles because they already had an adequate response. If we look at the results and we focus on the follicular lymphoma patients, overall response rate of 98%, this is pretty impressive, 87% complete response rate, and these results are durable. Overall survival so far is excellent, and if we look at the progression-free survival in follicular lymphoma patients, it's outstanding. These data have been confirmed in a phase 2 trial from the CLGB 50803. And so this is a multi-center trial, slightly different dosing of rituximab, but fundamentally a very similar trial. And fundamentally, very similar results. So we went from a single-center trial with an overall response rate of 98% to a multi-center trial with an overall response rate of 93%. We went from a single center with a complete response rate of 87% to a complete response rate of 72%. I would actually argue this is a remarkable confirmation of the MD Anderson data. So this was the basis for an important prospective randomized trial comparing chemoimmunotherapy with BR, RCVP, or R-CHOP on an individual patient basis compared to lenalidomide plus rituximab. This trial completed accrual in October of 2014, and we're all eagerly waiting the results of the trial. So how did this impact the NCCN guidelines? Well, first of all, we wanted to help clinicians, so we gave a preference order. We chose the regimens that have no difference in overall survival and are supported by high-level evidence. Rituximab as a single treatment is appropriate for certain patients, but for the typical fit patient with extensive disease, we felt it was less preferable and hence lower on the list. And you can see that rituximab and lenalidomide was category 3. A number of institutions said we really want it, but there was not uniform consensus. Why? Because we have excellent alternatives. Now, if this had been T-cell lymphoma and we had an emerging regimen that had results like we're seeing here, and in T-cell lymphoma where we don't have large-scale randomized upfront trials with multiple chemotherapy regimens, you know, we might take a large phase 2 that's been confirmed with a second large phase 2. But for follicular lymphoma, where we felt we had adequate data in large numbers of patients, rituximab lenalidomide, we said we need the results of relevance. But we also had to have options for patients who wouldn't be eligible for conventional treatment, either the elderly or infirm patients, and we have recommendations. Again, this is based on phase 2 data. The future, we will be changing this I can tell you today, we will change this in our January 2017 post-ASH WebEx, because the results of the Gallium study, which is a prospective comparison of rituximab chemotherapy versus obinutuzumab chemotherapy, will be reported, and I can report what has been reported in the press releases, and that is it is a positive study. You can go to ASH and see the details, but it is a positive study, so we will change the guidelines yet again. So what about post-remission therapy? Post-remission therapy in first-line follicular lymphoma is an area of substantial controversy among experts in the field. And we have certain options. We can do nothing. You're in remission, just watch the patient. We can do rituximab maintenance, and that will improve progression-free survival, but as I'm going to show you, it does not improve overall survival. Or we can use radioimmunotherapy, and that will improve progression-free survival, but again, not overall survival. And so here are the different maintenance approaches. This is the radioimmunotherapy trial. Patients who are in remission were randomized to either receive radioimmunotherapy after first-line therapy or observation. Big difference in progression-free survival, not a millisecond difference in overall survival. The PRIMA study, this is rituximab maintenance after after immunochemotherapy induction. These are mature results with 6 years of follow-up. You can look. The data quality is excellent. Very few censored events here. All of the censored events are out here with mature data. And big difference in progression-free survival and time to next treatment. But again, you cannot put a piece of paper between these overall survival curves, suggesting no impact on overall survival with maintenance rituximab. We have another trial that's informative, and that's the RESORT trial, and this was for low tumor burden patients, and they got rituximab induction, and then they were randomized to observation versus rituximab forever. It was a little bit tricky to give rituximab forever, but that was the randomization. At time of randomization, the patient groups were the same. The retreatment on relapse or maintenance rituximab had very similar responses, and the time to rituximab failure was identical. But if you got retreatment, it only cost 4.5 doses of drug. But if you got maintenance, to get the same result, you had to give nearly 16 doses of drug. I would argue that it's a lot cheaper, and if you have exactly the same result, that maintenance rituximab is not supported by these data. So post-remission therapy, PFS, is substantially improved. Overall survival is not touched. The follow-up is still a little short, but it's not terribly short. I mean, you know, PRIMA has 6-year follow-up. The radioimmunotherapy data has 5-year follow-up. So it suggests that you can delay treatment effectively and still have good outcomes. So how did this influence the panel? The panel said, well, gee, there's no overall survival benefit, but for certain patients, a dramatic improvement in progression-free survival really is valuable. Your 52-year-old patient with 3 kids in college who wants nothing more than not to be treated again until everyone's out of the house, everyone's taken care of, that person really benefits from a prolonged progression-free survival. A 73-year-old patient who's traveling all over the world and is enjoying life and does not want to necessarily come in every 2 months for a dose of rituximab, that patient maybe is not appropriate for maintenance. And so the panel decided that it's an option and you have to discuss it with your patients. So that's how we came to this conclusion, that it is an optional treatment for patients in the relapse setting. So in the last few minutes, I want to turn a little bit to the future. Can we add value to the equation? You know, we have a lot of lists, and can we somehow help sort out between the choices? Now, the problem is value has a lot of different definitions, but the NCCN position is that the patient perception of value is probably the most important. But of course, what's valuable to one patient is not necessarily the same as to another patient. So the idea was to try to create a mechanism to get at value, and the operational assumptions were that we knew the diseases on the individual panels. We're constantly recommending treatments. We know the safety data. We know the quality of the evidence. So we can take all of this and create what are called evidence blocks. And evidence blocks are to look at efficacy, safety, quality of the evidence, consistency of the evidence, and affordability. Actually, the initial version of this was cost, and then it messed everything up because it was backwards, because expensive things then scored high, and it was hard to visually interpret. So we actually changed it after the pilot in lymphoma that said, this is really confusing. And so what are these definitions? I'm going to go through these really fast. I mean, it's obvious. Efficacy, highly efficacious is a score 5. Palliative only is a score 1. That's going to vary from disease to disease, how it's interpreted. It's determined by the disease experts. So what's highly efficacious in lymphoma may be super efficacious in lung cancer. You know, I mean, you know, our bar is very high in lymphoma. You know, the bar in lung cancer in second line is not as high. So it is scaled to the individual disease. Safety, you know, same thing, 5, no meaningful toxicity, 1, highly toxic. Quality of the data quality, that we have really multiple lines of evidence that supports this, or down all the way down to, gee, this is just our gut feeling about what this regimen is about. Data consistency is different than data quality, okay? It's, you know, do we see the same result in the different trials that were done? And again, highly consistent 5, only anecdotal evidence 1. And then affordability, I already mentioned, we used very inexpensive as 5, and then very expensive as 1. I have to say that this dimension has been the most difficult, at least for the lymphoma panel members, because we really have a tough time wrapping our heads around this. The idea is to try to understand the full cost of care, not just the cost of the drug, but the full cost of care. So each node, there's a treatment decision. We generate an evidence block. I can't show you the lymphoma examples because they're still being tabulated in large cell lymphoma and CLL, but I can show you multiple myeloma. This is what the evidence block page looks like in the guidelines. So here are a whole bunch of recommendations for multiple myeloma therapy, and you can see here are the evidence blocks, and I'm going to blow them up a little bit. So here in the preferred regimens, you can see that, you know, this is a pretty good regimen. It's you know, highly effective. There's consistent evidence. There's good data quality. You know, but it's moderately expensive. You know, whereas here we also have pretty good evidence, but it's considered to be less expensive. This will help patients and caregivers make a decision among the various choices that are available. We're in the process of doing this. Because we have 500 pages of document, we have a lot of nodes. So we did it in large cell lymphoma and CLL. It was pretty consistent across panel members, and we're finalizing the recommendations. And then finally, I'd like to touch on another future element, and that is the NCCN recognized really quite early on that biosimilars were coming, and we had to figure out how to handle them. Actually, before there was even draft guidance from the FDA on the development of biosimilars, the NCCN convened a multi-disciplinary panel, including payers, pharmacists, physicians, patient advocates, industry representatives from both biosimilar manufacturers as well as originator manufacturers. I actually was the chair, and we published a white paper that actually did strongly influence the FDA guidance on biosimilars. So what is a biosimilar? Well, this is a biological molecule. This is aspirin. Making this molecule is a lot more complex. They're usually made in biologic systems. And so if we look at the manufacturing process, well, the DNA sequence, that's published, it's in the patent. Everyone's going to have the same DNA sequence unless you screw up, okay? The vector can be the same because frequently the vector sequence is published in the patent. That's it. Nothing else can be the same. Genentech is not sending a biosimilar manufacturer their cell bank for making rituximab. Okay? So everything else downstream changes. We have expression vector, the media, the source, the scale. All of these things can affect the molecule. And in fact, we know that biological molecules vary over time, and there are guidelines that say how manufacturers have to be really careful about changes to their manufacturing process. But all of these communications are confidential. They're between the agency and the manufacturer. So there are data, and this is an example of rituximab, of lot-to-lot variation analyzed at different times of commercial source drug. So differences in cation exchange, differences in ADCC. There was a process change that resulted in about a 10% increase in ADCC. Why is that important? Well, ADCC is probably the most important mechanism of action, certainly of single-agent rituximab. So the drug actually changed over time. And this is possibly in part due to a difference in glycan mapping. So there are multiple pathways to develop biosimilars, but the biosimilar pathway is 351K, and you have to develop a molecule that is virtually identical, but within certain limits, and it can't be absolutely identical because even the originator can't be identical to itself. You can never, you can't have two identical batches of cetuximab, can't have two identical batches of rituximab. So this is a shock and awe. This is the preclinical and functional characterization of GP 2013, a rituximab biosimilar candidate from Sandoz. An awful lot was done to show that they were the same, and here are some of the data. And I would argue which is the biosimilar and which is the originator molecule. One of them is one and one's the other. I would argue you can't tell the difference. It turns out the blue is the biosimilar. But interestingly, if you look at different lots of the originator, there's drift among different lots of the originator, but you can only make the biosimilar similar to one of the products. And so this is a challenge, a major challenge that we have in biosimilar development. But if you look at the X-ray crystallography of the biosimilar, it completely is identical. And it turns out that the functional characterization is actually a little tighter with the biosimilar than it is with the reference product. To prove biosimilarity, you have to have preclinical and clinical evaluation. And I'm not going to go into this in great depth, but so how does the NCCN take this into account? We understand that biosimilars are an opportunity to potentially reduce cost, and we want to evaluate the data, and if appropriate, they will be incorporated into the NCCN guidelines. There is a biosimilar now in the NCCN guidelines, in the supportive care and the growth factor guidelines. The filgrastim SNDZ has been approved and is in the guidelines. So it's a complex process to develop these algorithms. We have 23 therapeutic and diagnostic, it's actually 24 therapeutic and diagnostic guidelines. It's the largest set of NCCN guidelines for NHL that the NHL are. We annually update it, and frequently more than annually. I believe that we meet most of the IOM recommendations. Remember, I started out with the IOM recommendations were theoretical, and these are practical. Where there's inadequate data, you can't have high-level evidence, but I would argue a consensus makes more sense than to provide no guidance. I want to thank the panel members who've worked with me for years, and I suggest that people mark their calendar for May, because we're going to do some more lymphoma.